Hello, everybody. Welcome to It Is Possible with Dr. Sa. I trust you're doing amazing. I'm also doing very well. I'm very excited to come your way once again with another great edition of our podcast discussion today. Today, I have an amazing guest. I'm so honored and so privileged to have him join us today. Discussion is going to, dive into his journey to this side as usual, and also we're going to look into, a very critical, important topic that it's really being evangelized right now a lot in America, which is health equity and also social justice. So we're going to look at these conversations today. Well, my guest today, he is Dr. Yele Aluko. And Dr. Aluko is a medical doctor. He has an MBA. He is a physician executive and a corporate leader. Also, he has multi-year experience in healthcare, clinical, and administrative strategic planning, program growth, and development. He is seasoned in health equity and with a focus on solution development and deployment. Dr. Aluko is the CMO or the Chief Medical Officer and also the Managing Director for EY Americas. Well, Dr. Aluko, thank you so much and welcome to the podcast.
Thank you for the invitation. Pleasure to be here with you and with your audience.
So glad to have you here once again. So let's dive into it. Can you briefly share with us your journey, how you got into healthcare, and your journey to this point so far?
Well, it's been a long journey, but I'll abbreviate it. Essentially, I was born in Lagos, Nigeria, and I went to both primary school and secondary school, boarding school in Lagos, Nigeria. I went to medical school at the University of Ibadan Medical School. And after that, I did my mandatory housemanship 1 year, as well as a mandatory National Youth Service Corps. I came to the United States in June 1980.
Wow.
Quite a long time ago.
Yes.
When I came here, I came ostensibly with the intent to specialize in internal medicine, spent 3 years specializing, and my intent was to go back to be on faculty at the University of Ibadan. I did go back to look around in 1983. At the time, we were in the middle of one of our several military regimes, and the timing wasn't right. For a number of reasons. Most importantly was there had been infrastructural decay in medical schools, and then also begun the start of a brain drain at the time to the Middle East. So a lot of the faculty was disillusioned and began to seek different geographies. So I decided to come back to the US after doing a brief landscape analysis. I came back to specialize. I wanted to spend 2 more years specializing in cardiology and then go back. So I spent 2 more years specializing in cardiology, and I did go back to look around. And things were actually a little bit worse.
Wow.
And I also had opportunities here to further specialize in a field called interventional cardiology, which I came back, and that was an additional couple of years. So I had spent 4 years as a cardiologist in training on top of my 3 years of residency and the 5 years of medical school, and in between 2 years of housemanship as well as national service.
That's intensive.
It so turned out that having become a super specialist in America in interventional cardiology, the options for me back home rapidly dwindled based on infrastructural and technological capabilities that would support my skill set. So I decided to stay here and begin a practice. So I moved to Charlotte, North Carolina. My wife and I moved to Charlotte, North Carolina in 1989 and began a solo practice in cardiovascular medicine and interventional cardiology. Over the ensuing 5 years, from 1989 to 1994, I built a group of 4 cardiologists who were all African American, 2 Nigerians, and 2 American-born African Americans. My intent when I got to Charlotte was actually very deliberate, very strategic, was to build a practice of Black medical professionals.
Nice.
The goal was to show the community and the medical establishment that we could do it professionally, do it with pride, do it effectively, and make an impact in society. We were successful in so doing, and shortly thereafter, we were asked to join another group in town, which comprised of 8 Caucasian males and us 4 African American cardiologists. So we merged and formed the first interracial specialty practice merger in North Carolina in 1994.
Wow.
And that group of 12 grew to be a group of about 65 over the ensuing 20 years. I was president of that group for 6 years, and our group was eventually acquired by one of the healthcare systems here in Charlotte, North Carolina. I eventually became a physician executive within that healthcare system as senior vice president and medical director of the Heart and Vascular Services. That healthcare system comprised 14 hospitals across 4 states: North Carolina, South Carolina, Northern Virginia, and Georgia. And my role was to create a horizontal integrated platform across all 4 states to integrate our cardiovascular assets, develop strategy for growth, physician alignment, accountability, and so on. So having done that, or while I was doing that, I actually went to business school, and I got an MBA about 10 years ago. And the last 2 years of my clinical work, I began to have different interests, trying to understand the macroeconomic perspectives in the health industry in the United States. And I decided to retire from clinical medicine in 2016. And I joined EY, Ernst & Young, where I currently am. And as you mentioned, I'm Chief Medical Officer at EY in our Americas practice, which includes North and South America. And I'm also the inaugural director and the founder of the EY Center for Health Equity. So that pretty much sums it all.
Wow, that is amazing, really. One thing that I want to ask back home, when you went back, did you ever see yourself, and maybe I'm going ahead of our conversation, but I'm asking this because of, the progress and the successes and your accomplishment to this far. Did you see yourself getting to this far or this level in life?
Well, 10 years ago, I didn't think I would be where I am today. When I went to medical school, I thought I would retire as a practicing physician. I've tended to look at my life in snapshots of 5 years. And to answer your question directly, no, I didn't. When I left Nigeria, my intent, like I said, was to be back in Nigeria within 5 years. Home is where you make it. That's always been one of my driving mantras.
Exactly.
And I have remained very connected with the Nigerian healthcare ecosystem. And I firmly believe that one's journey in life is not necessarily a linear one. One cannot put data points into a computer and then data points of life into a computer and then, spit them out as an end product. The journey is not linear.
Right.
Opportunities come, directions change, but fundamentally, what I advise my mentees, and it's also one of my guiding principles, is to be disciplined in approach to education and work opportunities demonstrate integrity all the time, keep your eye open for opportunity, but fundamentally have some certain guiding principles that drive your life and your work. And one of my foremost ones is to be in a space where I can impact society and humanity.
That's powerful. That's powerful. With everything that you see in today's healthcare system, and also in comparison, going back to 1994, when you started the practice in, North Carolina, of course, there have been, advancement. Um, so there have been changes. What are the changes do you see in comparison to, when the time when you were in practice, when you started your practice in 1994 to today?
Well, there have been several changes. The healthcare industry and the practice of healthcare in America changes very rapidly from a very fundamental aspect, from the technology available to deliver care, the innovations in medical therapeutics, the changes in reimbursement, the changing expectations of the consumer, which is the patient. When I started practice, we were very heavily in an environment which we call fee for service, where
Right.
insurance companies pay physicians and hospitals for procedures that they do or for treatments that they dispense. The US healthcare industry is a tale of two cities, shall I say, a tale of two worlds, and somewhat of a paradox in that it is highly sophisticated, technologically driven. A lot of great minds in medicine in the United States, and a lot of excellent care delivered that people across the world seek, if possible, seek to come here for healthcare.
Absolutely.
Those are very, very admirable attributes. But on the other side, the health industry in America, compared to other Western economies or largest economies in the world, the US healthcare industry is inefficient. It's somewhat dysfunctional, a lot of players in a chaotic ecosystem that limits the value that is derived from the patient. So it's very expensive. Diagnoses and treatments can be made quickly and efficiently, but very expensively. And the issue of access to healthcare, which is a driver of outcomes, one of the main drivers of outcomes, of good outcomes, has plagued this country for decades. In that, while we have governmental insurance that covers people below the poverty line and also covers those above the age of 65 who have worked and have therefore paid into a pot that supports health insurance coverage after the age of 65. Those two buckets are the largest buckets of healthcare coverage. Then you have the commercial insurance that provides coverage for people who get this coverage through employment. But there's a gap whereby about 30 million Americans today that still do not have health insurance. And even those that do have health insurance may not have enough. So that gap drives limited access. And there's also the context of what we call the social determinants of health, whereby certain non-medical situations impact one's vulnerability to illness. Access to healthcare is one. Access to quality education is another. The quality education provides opportunity to have health literacy. And health literacy then puts one in a position to drive responsible lifestyle and health choices.
Exactly.
Also, where you live, housing. Do you live in healthy environments? Do you live in safe communities? Violence, death by violence is often predicated by where you live, and so on and so forth. The food you eat, you have access to good food. So these social determinants of health tend to create vulnerabilities that are more predisposed towards lower socioeconomic populations, marginalized populations, and those populations, even if they have insurance, may not have as good health outcomes as otherwise. There's more focus now from the federal government, as well as from the Center for Medicare and Medicaid Services that provides the largest bucket of healthcare coverage, and other regulatory bodies that regulate hospital systems and physician reimbursement, seeking to shift the focus away from what we call fee-for-service to fee-for-value, where the value to the consumer, the patient, is more objectively defined and measured. And the reason for that is to hold hospitals and providers accountable for the delivery of value. That's a major shift.
I think that was that. I think it was President Obama that passed that with the Affordable Care Act, and it was a paradigm shift in the healthcare space. Of course, with the fee for service, and probably you would attest to it, that there are really a lot of abuse of resources, which in comparison to the value, we can't see relatable value in the care outcomes in terms of patient improvement, health improvement. So, I mean, that shift from, fee for service to, value-based care, I think really it's a game changer. And one of the key aspects of this, and especially, taking it down to our community with a lot of with technology, making it possible for people to be able to document social injustices in the community. It has raised that awareness to the point that now policymakers have the attention. They know that they need to look into social injustices within the American system. But not only that, but how can we even translate that to healthcare as well? Right. And as you said, the government has the attention of that. Also, CMS also is really driving on this. And one exciting thing about this health equity and SDOH is that CMS, I think for some time now, they've been talking about really pushing SDOH, but we see it coming. In 2024 measurement year, where with a lot of these clinical measures, with this STARS measures, HEDIS measures, they're really starting to nail it down to health equity. So in the past, it used to be, for instance, if we're talking about comprehensive diabetes care, we can just talk about for let's say North Carolina, 90%. Adherent. Well, 90%, it could just be a subset of the population that is accounting to. That population, as an example, may not be diversified. Right. So CMS and, NCQA, which is the National Quality for National Committee for Quality Assurance, really are having this joint effort to, dive in to really take these measures down to the health level, at the race and ethnicity level. So if we're talking about diabetes care rates, HbA1c, or we're talking about blood pressure screening, or any of these preventive screenings, they want to see how all the various sects of race, ethnicity, how they are all doing. And I think that is really powerful. Of course, I mean, when that announcement came out, CMS, when they released their proposed, rules, it was a lot of concern because, number one, plans in the past they don't have the structure to be able to, number one, report this information. Even how to be able to get access to this information, it was a change. It was, a challenge. But I think CMS, they stuck to the gun. So the plans have no option to look for a way to be able to really nail it down and report with clinical measures at a race and ethnicity level, which is beautiful. With shifting to health equity, you are, a health equity leader. You're speaking at different engagements and in different conferences and workshop. Of course, it looks like, for me though, personally, and I don't know what you feel about it, it looks like health equity is becoming like a buzzword that, everybody just saying it. But do you think we are truly, truly realizing the impact, or we are moving the needle?
So, great question, and you brought up very important comments earlier on. But first of all, I think we should understand what health equity is, for the sake of the audience that may not be in tune with the conversations happening here. Health equity, the definition of health equity is the ability for any individual to achieve their maximum life potential, irrespective of their socio-economic background or any other type of social or demographic designation. In other words, in the United States, if people are born on January the 1st, 2024, 20 years from the date of birth, if health equity was present, all people born on that day should have similar health profiles.
Absolutely.
And we tend to measure health equity or lack thereof with several different metrics. I'll just mention a couple. One is life expectancy. In an ideal world, if health equity existed in America, Black, brown, white, Asian people born on the same day should generally have around the same life expectancy. Now, we know that doesn't exist.
Yeah.
Because there have been disparities in outcomes throughout the history of American medicine, where certain populations, predominantly non-white populations, specifically Black, brown, Native American Indians, tend to have worse outcomes. So the life expectancy for Black people is lower than the life expectancy for white people in America. So therefore, health equity is a level setter. It's important to understand that health equity is an aspirational context. It doesn't exist. It's the true north, the North Star. What we need to understand is that we get to health equity by eliminating health disparities. I've mentioned life expectancy. We need to understand why there are differences in life expectancy and develop strategies, solutions, processes to enhance the life expectancy of those that are marginalized. Another good example is maternal death, women that die during childbirth.
Right.
Maternal death in the United States for Black women is 3.5 times that for white women.
Absolutely.
That is another example of a disparity. And there are multiple disparities. Now, the ones that I've just mentioned have been tracked over time. You have mentioned CMS, you've mentioned NCQA. It is true that with COVID, health equity has become more of a national and a mainstream conversation. We have to be very careful that it does not become a buzzword. But I've been in this business of health disparity elimination throughout my career. I consider myself a health equity practitioner. That's for about 30 years, from when I was a fellow. And I'll give you a quick story as to what got me into this space. When I was a senior fellow, in Massachusetts doing interventional cardiology, I was doing pretty much 75% of all the sophisticated procedures with my supervising consultants. We call them attendings here.
Okay.
I was working with 3 attendings. So there are 4 of us that were doing the work, and I was training. And I would rotate across the 3 of them. So I was exposed to 75% of all the procedures done at that institution in 1 year. in 6 months, it occurred to me, my first 6 months, that I had done a procedure on one black person, just one, in
Wow.
6 months. Now, I was at a state university, a very prominent one in Massachusetts, that had open access to everybody. I was in a blue collar town just outside Boston, and there are a fair amount of black people there. So I began to wonder, how is it that heart disease is the number one killer of black Americans and white Americans, but more black Americans than white percentage wise? And how is it that me as a black cardiologist was not treating more black people? It drilled
It
down
dawned
to
on you.
access, awareness, trust, appropriate referrals, and so on. So that began my journey to study the issues of health disparities. And there are several issues that drive these health disparities in America. It's a very complex construct that starts from interpersonal understanding, interpersonal relationships a patient has with a physician or a health system, access to care, personal responsibility, health literacy, implicit bias within the health industry. And as we know very well, implicit bias exists in the society. And bias exists in human society in general.
Right.
It does manifest itself in very stark ways in the Western world as racial bias. And that level of systemic bias is also a significant contributor to differential outcomes in care.
You have really broken down, health equity. If I were to explain it, I don't think it would be this succinct like you have. So thank
Well,
you
it's my
for.
day job and it's not yours.
Right, exactly. There's one point that you made here, and I want us to touch on it. You talked about awareness. Like in your case, being a cardiologist, and sometimes we can get used to the system. We can get used to life, and we barely, or we may not even recognize the biases that exist, the biases around us, or even our own biases, right? So what I like from what you said is awareness, and also trust, which, for people of color, when it comes to the health system, there's that level of, trust that we don't have, due to things that have happened in the past. And like you mentioned, how blacks have been treated in general, when it comes to healthcare. Let's take it down to our level as diasporans, immigrants, and even nail it down to our African diaspora. In our community, and just as in any other immigrant, community, we have undocumented immigrants, right? And I'm saying this because the undocumented immigrants are not prone to seek care, right? They may have issues, they may have health conditions, mental health issues, but because of the fear of being deported, or the fear of going to jail because of lack of, documentation, they might keep it, which also does impact health equity and even health outcomes as well. So what would be your word, or what would be, going forward as far as a community, what we can do in relation to our undocumented immigrants?
Well, that's a good question. So people that come from Africa to the United States fundamentally come to seek better opportunities. And there's a large swath of us, them, across the diaspora that end up doing well, end up getting employed, or start businesses that employ people. And in those constructs, those people tend to have health insurance. And you speak specifically of undocumented diasporans. And the reason for being undocumented is likely because the personal situations that they have found themselves in do not lead for legal presence in America. And with that comes a fair amount of risk if there's exposure. And the risk is very, very clear. It is deportation.
Right.
So hiding in that bubble limits the ability for undocumented diasporans, irrespective of which continent they came from, it limits their ability to openly engage with opportunity, of which taking care of one's health, using the resources available here to optimize one's health opportunity. It's understandable why that happens. There are some undocumented situations that you may be able to get insurance through certain type of employment models. But the larger population of undocumented immigrants, and specifically you brought up African immigrants, it's a problem. So therefore, people like that tend to be vulnerable to risk, health risk, because they don't have access to primary care. They don't get physical examinations. They don't generally get physical examinations. And they present to physicians and hospitals when they're in more advanced stage of disease. And they have less likelihood to have efficient care beyond the sporadic emergency room visit. Efficient care includes not just making the diagnosis and starting treatment when you're in the hospital. It includes what we call chronic care management. What happens after you leave the hospital, after you leave the doctor's office? You're given prescriptions, you're given lifestyle change advice, and then you leave. But what happens when you leave? If you are homeless or if you're jobless, then nothing really happens until you get sick again and you come back to an expensive source of care, of healthcare, with a more compounded problem, and it becomes a vicious cycle. So the chronic care management behind the scenes is a problem for the entire industry, but it impacts vulnerable populations more adversely. Immigrant populations across the world are vulnerable to suboptimal healthcare, and by default, they're more vulnerable to health disparities. When I say immigrant population, undocumented immigrant populations, definitely. Correct. And even immigrant populations that have healthcare coverage are often exposed to cultural misalignment that results in implicit bias driving decision making on the provider side that might be influenced by bias, but it also may influence the recipient of medical information from the immigrant consumer side in a manner that they are not able to align with recommendations because of cultural misalignment. So it's a very complicated construct.
It really is. I mean, when you mention culture, like I think you mentioned before in your narration that health equity, there are a lot of players. And I think one key to it is cultural competency. Culture, it plays a huge role, even in building trust, in building that bond, that genuine bond with the member or with the patient. I say my member because in my ward, we refer to, we would say member instead of patient. But I mean, if that bond is there, then the patient is more willing to be able to share the challenges that they have. If that trust is there, because I think the gateway to this, of course, the providers would have to be able to capture this information and share the information with the appropriate resources or with the appropriate channels that will be able to take actionable steps to close those gaps. But again, if the members they don't feel secure, or they feel they can't connect, or they are misunderstood, or like you mentioned, biases, then they will not be able to share. I so much wish we will be able to really go on with this um, um, conversation, because it's really a topic that I'm very passionate about, because of also my line of work. I work with our dual eligible population, which is our DSNP population, which underserved population. Then we're always looking at ways that will be able to impact these members, because at the end of the day, if the patient doesn't have food to eat, if they don't have a place to sleep, they're not going to pay attention to you going, how can they even pick up the prescription?
Correct.
Right.
Correct,
So,
correct.
I mean, health equity, I don't think health outcomes can be attained to the utmost level without addressing social determinants of health, and all these other, lingering aspects to it.
Yeah. So
Dr.
I want
Aluko,
to touch on one
go
thing,
ahead.
if I may.
All right.
Culture.
Sure, go ahead.
Culture. Now, you and I are both from the African diaspora. When we come here, when I say we, I'm saying that it is somewhat a common theme when Africans come to America, not to understand the value of investing in educating themselves about the African American experience, therefore becoming culturally aware of that experience. In fact, it is more common for Africans, first immigrant Africans who come here, like myself and yourself, to have somewhat of a disdain to African Americans because of misinformation about their history and an unwillingness to learn what has driven what we see today. I feel that if you're going to live in the United States as an African diaspora, if you insulate yourself and your families from the reality of what has happened, and more importantly, an understanding as to what has happened, you run the risk of not being in a position to control your opportunities better. There is a whole body of intelligence that demonstrates a very vibrant African American middle class and upper class, educated. And in any society, you have that type of stratification. So we in Africa have been taught by the media, and you know who controls the media, that the reality of the African American experience, and as you live here now, you know it not to be true, is what we saw and we learned when we were back home. So that failure to adapt, I've seen it consist time and time again. A failure to adapt, a failure to probe, a failure of willingness to explore and to realize that the truth is we're Black in America and we will therefore share the same problems, which unwittingly, if you don't control your ability to negotiate the complexity, then it becomes harder for us, and most importantly, our children.
So if I understand from what you just shared, I think it's an interesting point. I'm coming to America. I'm here to work, make money, take care of my family. Live the life that I want. What is my own with learning the experience of Black Americans in America? I know probably that's the thoughts that is running through somebody's mind because they don't see the essence. But you just, raised a very important point. And I want you to maybe stress on it a little bit more. What would be the differentiator, or why do we need to be able to do it? I get it. We should do it, but what difference would it make? How is it going to help our experience as immigrants in America?
Well, first of all, I think that one has to understand that if you are Black in America, irrespective of your African country of origin, you are an African American. Therefore, you need to understand that designation, understand what has led to it being what it is today, and how you can be a change agent, an image builder within that community. Now, if I was in Lagos, Nigeria now, practicing, I would develop coalitions with people in Lagos, people of influence, both politically, economically, socially. I would strive to know who the governor of Lagos State was. I'd strive to know who the leaders of business coalitions in my country were. We should do the same here across all swaths of society, which includes white society and Black society. But to be prepared to navigate the bias that you may encounter within white society, you have to have an understanding as to why there's bias and understand how successful African Americans have become successful. There are many. I mean, the extreme of the most admired one that we know of is Barack Obama, but you got Colin Powell, you have Condoleezza Rice, you have several. The truth is that if Barack Obama was a white man, he probably, if he had his same genetic makeup other than his color of his skin, he may have become president 4 years earlier. I mean, he has achieved the highest of heights. But my point is that every Black person in the United States, irrespective of if you're a diaspora or otherwise, I feel we need to understand that you could have achieved higher heights, as successful as you may be, measured in different ways. Colin Powell is another example. He might have become a general 2 years earlier. Condoleezza Rice, she may have run for president. And we need to understand that and not think that because we were born in Africa that we are better. We were exposed to a different ecosystem. And had we been born here, those of us who are successful today, we have to question the likelihood of that success. And therefore, we need to not be critical. We need to empathize and be part of the building of the image. And I've often said in different environments that I think that brand Black across the world generally, and in America specifically, will change when Africa gets its act together. When we begin to be able to deliver as a continent global value in some form. Global value in some form. In a manner that gets the attention of the world, so that Africa as a continent, where we all came from, the image that the world has of our continent is what it is. So for us to come here and hide behind the successes we have and, so to speak, look down on the original Black people who were born here, suffered the painful legacy of slavery, for us to feel we're better when where we've come from is not good. I think that's anomalous thinking.
From what you said, from what I get from what you said, in relation to learning the African American experience, which I have to some extent, but I don't think it's something that, I'm just being honest. I don't think it's something that I have intentionally pursued to, understand or learn more of that experience. But I think, for what I get from it is because most of us, we have that aspiration to live our dreams, to be able to break barriers. And in some of these spaces, they are, white dominated. So understanding this from what you shared with me, understanding the lived experiences of the African American would help to be aware of the biases that exist. So when you understand the biases, then you become much more aware. And that will help to be able to navigate because you're aware of what exists and you're able to, well, you know how to move, how to make decisions, how to strategize in terms of growth, whether professionally, even in our personal life, or whatever the case may be. It's so powerful. I want to pick your brain on this. You touched on if the brand Black will gain its respect, global respect. It needs to start from Africa, the continent. I so much resonate with that. Of course, I think we still have a long way to go. There have been a lot of progress, but there's still a lot of work that needs to be done. What is your take? I personally think the way forward, as far as Africa getting to the next level, it starts with we first. Of course, it's easy to blame leadership. It's easy to point fingers at leadership. Decisions and policies that have been made by leaders that may have impacted the affairs of Africa right now, the continent right now. But I think going forward, I think it's the responsibility of every African to help shape that destiny that we all want for our continent. That is my belief. And the reason why I believe so much in this is because the leaders that we want to blame, that we want to, say they are not doing well, they are not leading well, they were once an average citizen, an ordinary citizen with no title, with no positions. And, they later on find themselves in a leadership position. The case of they are not, governing well, or they're not doing well, they're not leading well. It could be true. It could not. But then I believe that from a personal standpoint, if we live our life, as you mentioned, with integrity, we have life guiding principles that will lead us in every level, in every sphere of our life, regardless of the position. We are going to be able to do very well because we have our own personal guiding principles that we live by. So then when we get to that level, whether we find ourselves in decisions where, there's an opportunity to embezzle money, because of the principles that we have, we're going to shun those behaviors, right? So my own personal belief is that, look, yes, these leaders that we see today, give it the next 10, 50, 20 years, they may not be there. We're not saying anybody should die, but some may probably not be here with us. There's going to be a new breed of leaders in position. Now, the new breed of leaders that are coming in, if they don't have their personal principles in order, we're still going to see the same type of leadership that we keep complaining, we keep talking about every day. African leaders are not good. At the end of the day, they were once human being, they were one average ordinary people, and they found themselves in leadership position. I'm not sure if I really laid my point, but what is your take on this?
You make good points. We need to remember the history of governance in the westernized and other democratic countries. It didn't happen overnight. Our trajectory is much younger when it comes to shall I say, democracy. I'm not saying that democracy is the only way, but based on our past colonial ties and relationships, we were birthed into environments of democracy. But good governance is not handed over to a country. A country has to mature through growing pains. It seems like we are taking longer than we would have expected to achieve good governance that lays down institutions, leadership that is accountable for strategy execution. Now, none of us has a crystal ball, but I will say that I'm optimistic. We have certain spots of hope on the continent, but I'm optimistic that with this globalization of the world, where we now have first, second, third generation African diasporans across the globe, some of those second generation Africans that have stayed close to their roots and have developed the skill set I was referring to, developed skill sets to integrate meaningfully in their current locations abroad, where they've developed networks in low and high places. And they've learned the discipline of good business and good governance. Those subsets that have kept to connected with their home roots see the massive potential for business growth and for global value delivery on the continent. And they can potentially unlock that because they've got tangible relationships on the continent. So they're bringing a different level of intelligence, a different level of discipline, connectivity. And there are many people on the continent that have discipline, have integrity, just haven't had the opportunity to unlock those competencies within an infrastructure that works. So I'm hopeful that my children's generation that have stayed connected both here and there, getting the best of the best here and staying in touch with what's happening there, will be the enablers for change through the next generation.
That's powerful. Impact. Absolutely. Absolutely. Well, Dr. Aluko, it's been an amazing time, fun and great discussion with you. I really appreciate you being here and spending, sparing us with your time. And I look forward to even a future discussion on other topics. I know our conversation took a different turn from what the plan was, but I think we're just going with the flow. So it's all great, but really I appreciate you being here, sir.
I appreciate the opportunity and love to stay connected. Congratulations
Same
for what
here.
you're doing.
Thank you so much. I appreciate it. Well, thank you so much once again. Enjoy your weekend and have a good one, everybody.
Thank you. Have a good day.